Thank you. I'm Jong Kim from South Korea. I'm going to talk on brainstem cerebellar stroke syndrome. If you look at the anatomy of a brainstem, you can see the motor system indicated by green line here. Is here in the relatively ventral part of the brain stem. This motor system includes the pyramidal system, but also corticopontocerebellar system and corticobulbar systems. So clinical presentation usually depend upon the proportion of fibers involved, including hemiparesis or ataxic hemiparesis or dysarthria Crumbs-Hand syndrome. The sensory fibers are located a little bit dorsal to the motor system. And in far dorsal area, there are multiple cranial nerves here. And if you look at the vascular system, all pons, medulla, or midbrain are supplied by branches arising from a vertebral artery or basilar arteries. So it happens that these vertebral basilar arteries are located in the ventral rather than dorsal part of the brain stem. So in fact, usually occur in the ventral part of the brain stem like this. So in fact, a butt on the surface like this or like this, but another infarct can be isolated in the deep brain area. Anyway, these ventral parts are preferentially involved, so we can assume that motor system dysfunction are the most important and prevalent clinical presentation in brainstem stroke patients. I will start with the pontine infarction. That is, pons is supplied by basilar artery branches, and this is a motor system, sensory system, and cranial nerve system. The paramedian area, there are structure called the medial longitudinal fasciculus, MLF, is often involved in pontine midbrain, midline infarct patients. So if the lesion occupied only the ventral part, motor system, then it will lead to motor dysfunction, including hemiparesis, ataxic hemiparesis, or dysarthria Crumbs-Hand syndrome. If it is a little bit extended dorsally as to involve the sensory fibers, that it will lead to sensory motor disturbances. If the lesion is located in the dorsal midline or dorsal area in isolation, then it may involve sensory tract, leading to predominantly hemisensory symptoms in these patients. If the lesion is far dorsally located in here, it may involve MLF, medial longitudinal fasciculus, leading to internuclear ophthalmoplegia, sometimes isolated internuclear ophthalmoplegia. If the relatively large lesion involve ventral to dorsal part of the pons in a whole, that it will lead to motor sensory dysfunction and oculomotor dysfunction, but in a unilateral manner. But sometimes lesion occur bilaterally, then it will lead to bilateral motor dysfunction, sensory dysfunction, or oculomotor dysfunction. This is actually one of the worst types of the stroke, so leading to so-called locked-in syndrome. This one, on the other hand, is very benign. We call it anterolateral infarction, not anteromedial. Medial part is spared, so motor dysfunction is not severe in these cases, so this is a relatively benign condition. It usually is due to occlusion of the circumferential artery arising from basilar artery, superior cerebellar artery, or ACA, rather than anteromedial branches. So these are typical cases of pontine infarction. There, of course, are some rare but atypical cases. I'm showing one atypical case. This patient suddenly developed left facial palsy, including upper facial muscle. So this is a really actually identical with peripheral facial palsy. So I usually do not order MRI in this type of patients, but she happened to get MRI from other hospital and brought it to me. So whether we wonder whether the infarction in the pons may lead to peripheral type facial palsy in isolation. It is indeed possible. This lesion was responsible for her symptoms. Actually, facial nerve nucleus is here in the middle of the pons here, but the fibers do not go out directly, but go backward to the ventricle and encircle the sixth nerve nucleus, make a loop, and then go out in the lateral part of the pons. So probably this small lesion selectively involved this portion of the facial nerve. We call it genu portion of the facial nerve. This is involved in here to lead to peripheral palsy like facial palsy. You can imagine where is the location in this patient. This patient show INO, internuclear thermoplegia. He is looking at the right side, but right eye goes to the right side, but left eye does not go to the right side. This is INO, internuclear thermoplegia, on left side. But he also had some facial palsy, peripheral type facial palsy here. So how can we explain INO plus facial palsy, sometimes called 7.5 syndrome? The very similar lesion, but lesion looks a little bit wider than previous one. Probably that involved genu portion of the facial nerve as well as the MLF here. So involvement of both structure can lead to INO plus facial palsy syndrome. So what about midbrain? Midbrain is also supplied by basal artery, but it is also supplied by PCA, especially in the lateral part of the brainstem. So the motor fibers here is here in the peduncular area. It is supplied by PCA rather than basal artery. So if the patient have a motor symptom, it is usually due to PCA disease or perforators arising PCA should be examined here. The basilar artery disease or perforated disease usually lead to third nerve palsy because third nerve nucleus is here. Fascicles are going in this direction. So this will lead to third nerve palsy when the location of the lesion is upper part of the midbrain. When it is a lower part of the midbrain, it instead involves MLF leading to INO. But if we look at the literature, the most common manifestation of midbrain is ataxia or dysarthria. We can explain this phenomenon in this way. There are a lot of cerebellar fibers in the midbrain. Descending corticopontocerebellar fiber in the peduncle that goes to the right contralateral cerebellum, but ascending fibers also cross the brainstem and go up in the medial part of the midbrain in the red nucleus. So there are abundant descending and ascending cerebellar fibers. So cerebellar involvement is very common in midbrain infarction patients like this. So there are some pattern of a midbrain infarction. Pattern A and B are most common. A is caused by a basilar artery or P1 disease or perforated disease. The infarct pattern is very similar to Pontine infarction like this. Some abut on the surface, some was isolated in the deep brain. In any cases, third nerve nucleus or INO are the dominant clinical manifestation in patients with anteromedial infarction. B is also common. B is anterolateral type of lesion. It is due to PCA disease or perforated disease here. You can see PCA stenosis here that probably obliterate the orifice of the perforated artery supplying midbrain peduncle here. As you can expect, this type of lesion usually produce motor syndrome, hemiparesis, ataxic hemiparesis, or dysarthrial clumsy hand syndrome without any clinical nerve involvement. C and D is quite rare, but C corresponds to sensory system, medial limbic system here. So this type of lesion here usually produce pure sensory stroke or dominantly sensory stroke. In fact, isolated in D part is extremely rare. Actually, this is supplied by superior cerebellar artery. So in fact, here is usually accompanied by cerebellar infarction like this one. Cerebellar infarction involving part of the dorsal brain, midbrain here. So this is again unusual case. Think about the location. 38-old year, healthy male, suddenly had right facial tingling sensation and diplopia. An examination showed only right superior oblique palsy. How can you explain these symptoms? The lesion is here in D part. This is a small hemorrhage, probably due to vascular malformation. This lateral part, there is a sensory tract here. So this lesion probably involved most medial part of the sensory tract going to subserving facial sensation. And third nerve is here, the fibers going in this direction. But fourth nerve here, the fibers are going outward, go out of the midbrain and encircle the midbrain, and then go to contralateral eye. So probably this small lesion involved a portion of the sensory tract and fourth nerve nucleus or fascicle, leading to contralateral facial tingling sensation and contralateral superior oblique palsy. Sometimes ataxia in the middle brain infarct patient become a persistent tremor. We call it ruboral tremor. This is a jerky tremor about 4.5 hertz, sometimes with delayed onset. It is usually due to ruborothalamic pathway involvement, although there are some argument that nigroyl dopaminergic fiber should also have been involved in these cases, but we don't know. This patient has a lesion here near red nucleus. She has such problems, ataxia, some changing into permanent oscillatory limb tremor and bilateral ataxia. Now I'm going to lateral medullary infarction. We use a lateral medullary infarction because in the medulla, unlike pons or midbrain, the vertebral arteries are located in the lateral part of the medulla. So in fact, perforating arteries goes in this direction. In fact, occur in this manner. So I think to understand lateral medullary infarction, we have to deviate our posture to understand those syndromes. Anyway, the anatomic structures are similar to the pons. Pyramidal fibers are here in the ventral area. There are sensory system here, cranial system here. So because the lesion occur here, motor fibers are entirely spared. That's good for lateral medullary infarction patients, but they will suffer from numerous sensory or cranial nerve palsy syndromes. Initially, Wallenberg described ipsilateral trigeminal and contralateral body limb sensory pattern. This is a very typical, but not necessarily most prevalent type of sensory symptom. Sensory symptoms are actually quite variable in lateral medullary infarction patients due to the involvement of pattern. This is descending trigeminal fibers going from the pons, then go down to the cervical area, then cross, and then it will go up through the ascending trigeminal system in the medial part of the medulla. The spinothalamic tract is located in the most superficial part of the medulla. Arm localization here, leg area are located in the lateral part. So if B and A are together involved, it will produce contralateral body limb sensory loss and ipsilateral trigeminal sensory loss, just as Wallenberg described. But if lesion involve B and C ascending already crossed trigeminal sensory fibers, that it will lead to contralateral trigeminal involvement. If the lesion involve all A, B, C altogether, then it will involve bilateral face here. If superficial lesion involve only B, then faces will be spared, as in these cases. So these are various type of sensory patterns shown in lateral medullary infarction patients. And we also see in patients with a very low lesion, it will produce ipsilateral sensory system, some tingling sensation on the hand, something like that. Because this lower lesion may involve the lemnical tract before it crosses to the opposite brain. So this is also one of the sensory manifestations of a lateral medullary infarction. There are big differences between caudal medullary infarction and rostral medullary infarction. In caudal medullary infarction, the infarction lesion is very small and superficial. Nevertheless, it can involve a large portion of the spinal cerebellar tract located in the most lateral part of the caudal medulla, and also vestibular area here. So the patients suffer from severe dizziness and gait instability. Usually they cannot walk. They even have difficulty in sitting. But dysphagia is surprisingly rare or non-existent because it rarely involves deep structure nucleus ambiguous. And also nucleus ambiguous is a vertically long structure, and only the upper portion of the nucleus ambiguous is involved in soft palate movement. So even if there is a large lesion here, dysphagia is usually minor. And because the lesions are very superficial, sometimes sensory symptoms are very limited to the leg or some lower part of the body. On the other hand, if we look at upper medullary lesion, the vertebral artery here is going up more ventrally to make some ventrally located lesion, sparing dorsolateral area where inferior cerebellar peduncle and ventral nucleus are located. So they usually have minor dizziness and ataxia, but it can involve heavily the upper part of the nucleus ambiguous, leading to severe dysphagia. So they suffer from aspiration pneumonia. They sometimes need ICU care. So prognosis-wise, this pattern is worse than this pattern. There are, of course, intermediate pattern. In the most rostral part, if the this vertebral arteries are involved, then it lead to medial medullary infarction. I will show here. So that's the reason why medial medullary infarction most frequently occur in rostral medulla, because this is the rostral part of the medulla, just before two vertebral arteries are connected to form a basilar artery. So infarct pattern is very similar to PONS. The small lesion here will lead to motor system involvement and motor symptoms. B involvement will lead to motor and sensory system. ABC, all involvement will lead to motor system, sensory system, and cranial lobe dysfunction altogether. And if this is bilateral, the prognosis is very bad. Fortunately, this is less than 10% of cases. There are very rare cases in the middle or in the dorsal part of medulla. It actually leads to hemisensory symptoms in the patients. It leads to oculomotor dysfunction without any signs of medial medullary infarction. I think I can skip cerebellar infarction due to time limitation. So finally, I'd like to talk a little bit about invisible behavioral syndromes related to neurochemical change, because in the brainstem, especially pons or the midbrain, there are a lot of serotonergic fibers. So if they are involved, they have a serotonin deficiency, which will lead to depression, emotional incontinence, that is excessive laughing and crying, and anger that occur in more than 30% in brainstem stroke. So you have to keep that in mind. This patient have right hemiparesis and dysarthria, but the symptoms improved quite well. But still, he was unhappy and came to me. I asked him that, do you have some excessive crying or laughing? He agreed on that. So this is actually treatable because if we administer SSRI, that can be easily corrected. So I think we have to pay attention to this syndrome. I have nothing particular to conclude. So I would say thank you very much for your attention. Thank you.